This is Dr. Roger Young presenting monitoring uterine contractions during labor, current challenges and future directions. Speaking on behalf of my co-authors, Pernilla Marinescu and Neil Seligman, both at the University of Rochester Medical Center, Division of Maternal Fetal Medicine. The disclosures are as you see. I am the founder and chief medical officer for Pretel. I will not be talking about any products or promoting any products in this presentation. Drs. Marinescu and Seligman are faculty at the University of Rochester Medical Center, Division of Maternal Fetal Medicine, Department of Obstetrics and Gynecology. In this presentation, we'll be talking about uterine contractions, what we really need in order to be monitoring them more accurately or better to help with clinical decisions, how to evaluate abnormal uterine contraction patterns, and perhaps what to do about them. But in order to get to that point, we'll be needing to talk about organ-level models of uterine contractions and how they've evolved over time. Of course, the organ-level models are based upon forces that dilate the cervix, and the forces are created by the tissue or the myometrium, and the myometrial forces are created by the forces produced by the individual cells or myocytes. Along the way, we're going to be talking about the uterine pacemaker, or if there is one, something has to begin or initiate a contraction, but is it a fixed pacemaker, or exactly where is it if it is a fixed pacemaker? And the role of action potentials and how action potentials propagate and how far they can propagate, and new observations about action potentials in the uterus. So jumping right into the cellular function, the key here is calcium, intracellular free calcium specifically. And what we see is at this point, there are multiple ways to regulate intracellular free calcium, and it's very tightly regulated. The bottom line is that when calcium is extremely low, less than 100 nanomolar, the cell is relaxed or in its tone position. And when the oscillation hits, action potential hits the cell, the calcium rises to almost a micromolar and the cell contracts. So it's essentially an on-off situation. The excitation-contraction coupling is the technical term for the contraction when calcium is elevated. But myocytes are largely either on or off, and that to increase the strength of a contraction requires recruiting more myocytes. Now the exception to that is calcium sensitization by oxytocin through the Rho kinase system, but that's a little bit beyond what I wanted to talk about today. The other key point is that action potential causes myocytes to contract and also provide the signal that are passed on from one myocyte to another myocyte that actually provides the coordination at the tissue level. Myometrium has a definitive structure. The myocytes are joined together into bundles. The bundles join together into fasciculata. And then the fasciculata are actually the contractile units, or what I call the uterine functional units of contraction. Briefly, the microanatomy in figure 2A is that the cell is about 1/2 millimeter long. They are all interconnected with gap junctions, and attachment plaques actually form the mechanical attachments of one cell to another to allow this syncytium to work together as a functional unit. In B, we have the slightly more upscale microanatomy, where the bundles are about a 1/10 of a millimeter in size, and many of them, more than 6 or 7, form the fasciculata, which are about 1 millimeter in diameter. There are some bridges of myocytes that help connect the fasciculata together, and in between the fasciculata is connective tissue, which contain all of the necessary arteries, veins, and sensory nerves. Between the cells within the bundles is called the interstitial space, and that's not connective tissue, that is basically fluid. To address the question of how the uterus actually creates contractions, researchers at the University of Arkansas have been using a system with 151 sensors to map the electrical activity of the uterus during a contraction. Now, the sensors are very special sensors. They are sensitive to magnetic fields produced by bioelectricity, but nonetheless, they do provide a picture of how the uterus produces a contraction. What they found was the uterus does not have long-distance action potential propagation. As a matter of fact, the propagations are limited to about 10 centimeters, and that the activity suddenly appears at different locations and not specifically at the fundus or any fixed pacemaker. We discussed that there was no long-distance action potential propagation, but there is action potential propagation over short distances, approximately 10 centimeters. And that mechanism is responsible for recruiting myometrium to participate in the contraction over those distances. The mechanism for long-distance signaling we'll get to later, and as an advance on that, it's called mechanotransduction. But all of this means that peristalsis cannot be the mechanism of uterine signaling. This brings us to recording and monitoring uterine contractions. I'll be using Cohen's paper from 2017 as a springboard, and these are actually the points that were made in that paper. So the first one I talk about is that TOCO itself provides the same outcomes as palpation by a bedside provider. Now, this could be due to any number of reasons, but basically the three that I could think of were that TOCO doesn't provide any additional information other than palpation, that TOCO provides information that's incorrect, or that we are unable to figure out how the TOCO tracing actually applies to labor. So we don't really know which of those three reasons it is, but we're not going to figure that out until we get the organ level mechanisms worked out and a lot more studies performed. Second point is that TOCO reports only the change of contour of the abdomen and not intrauterine pressure. What happens here is that as the intrauterine pressure rises, the uterus changes shape, and the TOCO reports that. But when the shape change has been fully accommodated, the intrauterine pressure can rise further, and the TOCO won't report any additional shape change. So, in other words, TOCO is not an accurate representation of intrauterine pressure. It's not only not quantitative, but it doesn't reflect intrauterine pressure profile accurately and under all conditions. Next point Cohen presented is that there is a dissociation between the progress of labor and uterine contractility. He actually emphasized forces of that the uterus was producing, and that's very true. We just don't understand how the forces are produced, and we don't. And obviously, there are many other things such as cervical compliance and tissue differences and pelvic structure differences and things like that. He noted also that electromyography was in its infancy at that point in terms of being used and applied in patients. Now it has been fairly well accepted and it is expanding in use. There are several fetal monitors that are FDA cleared, and there's one that is in use at the current time. The current embodiment of the monitors really provide the same information as TOCO: when a contraction occurs, the peak of the contraction, and the frequency of contractions. But there's really not much else out there, although there's been a great attempt to provide information that goes beyond contraction frequency. For example, Cohen's point that the EMG has the potential to provide more information has been looked at for a number of years now, specifically looking at frequency of signals, EMG signals, the particular amplitude or power of the signals. But to date, nothing has really come of that that's been able to be put into practical use. The fact that uterine electromyography detects more false positive contractions than TOCO is based on the fact that bioelectrical activity is seen that doesn't traverse the entire uterus. It's not disseminated throughout the entire uterus. So you have bioelectrical activity without a contraction, and hence you have false positive contractions. Finally, the fact that UEMG reliably detects more contractions than TOCO in obese patients has held up, and that's very true, as well as the comfort level, and probably is two of the key reasons that UEMG is probably the wave of the future in terms of monitoring. So here's a uterine contraction pattern that some people would call abnormal. It does not look like a regular contraction pattern that we like to see. However, my definition of abnormal is going to be any contraction pattern that fails to result in cervical dilation or that doesn't advance the progress of labor. But clearly this contraction pattern is not one we'd like to see. The question is how do we manage this and what would we do? And before we answer that question, I think it's important to look at the models of uterine contractility that actually create these contraction patterns. Historically, the first model that attempted to explain uterine contractions was put forth by Caldera-Barcia, and it was called the triple descending gradient. The three components of the gradient are the direction, which is from fundus to cervix, and once it was started, it decreased in strength and it decreased in duration as it went down went down towards the cervix. He envisioned two fundal pacemakers, one located near each fallopian tube, and that they could alternate in terms of sequential contractions, but there was no specific pattern that was envisioned. The term commonly used to describe uterine contractions is peristalsis. Peristalsis does apply to the non-pregnant uterus, but in the pregnant uterus, the mechanism has some problems. It is really a modification of the triple descending gradient model. However, there are several distinguishing characteristics of true peristalsis from the Caldera-Barcia model. The first is that in peristalsis, none of the contraction that actually starts persists throughout the entirety of the contraction, and so there you get a very narrow band of wave that actually passes down towards the cervix. However, the term as it's used today may be referring mostly to the Caldera-Barcia mechanism rather than true peristalsis. Within a decade of the postulation of the triple descending gradient model, some relatively strong data came out that showed that the uterus did not really produce the initial activity at the fundus, that it could really occur anywhere. That information led Chapo to propose a multiple pacemaker model, where actually any cell could become the pacemaker of the uterus. And in this particular series, it's diagrammed as one yellow spot, which is the initial pacemaker activating, and then it sort of doesn't go anywhere, dies away after a very brief time, and then maybe a second one will pick over and die away. But eventually one will dominate, and that's the key issue with the multiple pacemakers model, is that one dominates, and that the reason it dominates is because the speed and propagation velocity of that particular contraction somehow allows it to encompass most of the uterus. So you end up with long distance propagation of the action potential from a dominant pacemaker that is selected from multiple pacemakers. Both the triple descending gradient of Caldera-Barcia and the multiple pacemaker model of Chapo envisioned that long distance action potential propagation was what recruited most of the uterus to synchronize and become a really strong contraction of labor. However, the recent data has shown that that actually probably doesn't occur. So to accommodate that finding, we proposed that mechanotransduction is actually what's responsible for long distance recruitment of myometrium to participate in the contraction. So the way this works is that one cell will fire, one region area will fire, and the region will grow to a certain distance, and as from the Arkansas data, it's about 10 centimeters, we believe. That raises the intrauterine pressure just slightly, and that slight raise of intrauterine pressure causes tension to be increased throughout the entire wall of the entire uterus. Then the next most susceptible region mechanically will exhibit a bioelectrical activity, contract, and the action potential will propagate about 10 centimeters, and then that amount of tissue will be contracting. So now they have two or a very small number of regions contracting. And then this process is a regenerative process, and as more regions contract, the pressure goes higher and more regions are recruited to participate in the contraction. At the peak of the contraction, most and perhaps all regions of the uterine wall are simultaneously or synchronously active. Following the peak of the contraction, the individual regions relax and the contraction dies away in a relatively random fashion. Again, the difference in this mechanism as opposed to the Calderon-Garcia and the Chapo mechanism is that long-distance action potential propagation is not responsible for recruiting most of the uterine for the synchronous contraction. So this is the pattern that was presented earlier and somewhat described as abnormal, although it's hard to describe or hard to differentiate between normal and abnormal by looking at a tracing. Nonetheless, there are basically two peaks in the doublet, and patient A has the first contraction off scale that's so strong. Of course, this is a toco, so it's hard to tell how strong the contraction really is. And patient B has the second contraction of the pair being stronger. So with a single pacemaker of Calderon-Garcia's model, it's relatively easy to see that there could be almost like a double firing of that pacemaker. So this really doesn't exclude the fact that there could be a single pacemaker that fires twice. However, that would be recruiting the same tissue to participate in the contraction. And from what we know about how the myometrium is refractory, it's really kind of difficult to use that model to see how to get doublets. If you use the alternate pacemaker locations, the two pacemakers of the triple descending gradient model, then it's hard to envision how to get the second firing to be exactly paired temporally anyway with the first. With the Chapo model, it's sort of the same problem. How do you get bioelectrical activity to pair with each other from different sites? It's just a little bit more of a difficult problem to envision. With a multiple pacemaker model, in this particular case, there are simply two very susceptible regions that will initiate the uterine contraction. And when that happens, as soon as there's a pressure rise, that initiates the contraction in the second region. And that there's sort of a distribution of susceptibilities of the different parts of the uterus, that the first region will activate its own select susceptible regions, and the second pseudo pacemaker will activate the other components. In this slide, we have the effects of prostaglandin placement on the cervix for cervical maturation. Before we go any farther, I'd like to emphasize that this is interpretation of the tracings only and should not be construed as to offer advice as to how to treat these patients, because any sort of clinical maneuvers or any clinical therapies have to consider the entirety of the patient picture, and all information needs to be gathered before making any clinical decisions. So these next few slides will be interpretation of the contraction pattern based upon the models presented above. So prostaglandin in this case is administered for cervical maturation of an unripe cervix in anticipation of a term induction. And before the prostaglandin is placed, we see relatively mild contractions per patient reporting, occurring about every 6 or 7 minutes, with some mild irritability that she does not perceive in between. After the drug is placed, you see relatively distinct peaks, but the really key element of this is there's very little rest period in between uterine activity. It's almost continuous activity with maybe a minute or so rest in between. So this could be concerning. It could be this could be interpreted to say, well, perhaps this patient is in tachysystole at this point. But yet the sharpness of the peak sort of implies that there are multiple activities going on, multiple local activities within the uterus. This doesn't really fit very well with a single pacemaker of the triple descending gradient model. It's very difficult to envision how a single pacemaker, or even two pacemakers, could do this. The Chapo model is a little bit easier to understand, that there are multiple areas that are firing off. None of them have really achieved the sort of dominance yet. And the dual model would agree with the Chapo model. In this case, oxytocin is administered, and we see very few contractions, maybe one every 10 minutes or so before the oxytocin is begun. And then early on, low doses of oxytocin, we see an irregular pattern. Again, it's reminiscent of the prostaglandin patient discussed previously. We see a long period of contractions, maybe 6-7 minutes, with no rest during that period at all. And the sharpness of the peaks, though, sort of imply that there are multiple pacemakers or multiple pacing areas firing sequentially, and that there's very poor synchronization of the uterus at that point. As the induction proceeds and oxytocin dosing is increased, the late effects show that the contraction pattern is every 2 to 3 minutes, maybe 4 every 10 minutes, and the peaks are very regular. This is a TOCO tracing, so this is a qualitative tracing only. So the early effects, again, even more so than the prostaglandin effects, could be seen as a tachysystole and inadequate rest. So the question is, from this tracing, from the early effects of this tracing, should the oxytocin be discontinued because of concerns about tachysystole? Should it be held because and not increased, or should it be increased in order to increase the synchronization? Well, oxytocin, of course, increases the frequency and the strength of the contractions. In this case, the strength of the contractions is increased so that the synchronization occurs, and eventually in the late effects, we see a regular pattern every 2 to 3 minutes. This is most consistent with the dual model, where the multiple susceptible regions are really recruited together, and the synchronization occurs following increasing oxytocin. Next, I'd like to address 7 questions that refer to fetal monitoring and the measuring of uterine contractions and activation of the uterus. These are 7 questions that I feel are important, and if you ask any of the other researchers in the field, I think you'd probably get 7 different questions. But I think these are important to address in the near future. First is what triggers the onset of labor, or even is there a trigger? There may be multiple mechanisms in order to start the contractions, and right now the field is wide open. Practically speaking, uterine activation is required in order to, we think the uterine activation is required in order to have the uterus begin contracting. So the question is, can uterine electromyography detect activation so that you know that there has at least a possibility of the uterus going into labor? Next, we've really spent a lot of time trying to measure contraction strength non-invasively. This could be used many areas, specifically for the diagnosis of preterm labor, but also can be used in the term setting as well. If the mechanism of mechanotransduction is important, I think it's extremely important to find out what the cellular mechanisms are. If we can approach mechanotransduction pharmacologically, we may be able to stop at least coordinated contractions and decrease the strength of contractions. The frequency of contractions are really the only quantitative thing that we have on labor and delivery, and the relationship between the frequency of contractions and the strength of contractions is really kind of unknown at the current time. And I think we need to assess what determines the frequency as well as the relationship between the frequency and the strength of contractions. The preterm labor concept is really a clear need medically. We need to be able to diagnose preterm labor better. We need to be able to treat it better. But we don't really know if preterm labor and term labor are the same processes, the same mechanisms. I think there's some recent indications that they are not the same. But if they are not the same, we need to determine what the differences are and how to attack preterm labor differently than term labor. Lastly, there's a question that I present. It's more philosophical. It's what are the important clinical questions that we should be looking at for contraction monitoring? We kind of already have the one of assessing the strength of contractions, but there are other important clinical questions that we really just haven't even thought about. And I think we need to think on this topic a little bit in a little bit more depth in order to find out some things that we can actually improve in terms of measuring contractions and how they'll be able to help us manage labor. I'd like to thank you for listening to the audio. And I'm Roger Young, and on behalf of my co-workers, Pamela Marinescu and Neil Seligman, I'd like to thank you again. I have some speculations and physiology pearls that are placed here. Feel free to pause the video and take a look at those. Thank you again.